Good evening, everyone, and welcome to our third Research Club of 2022. This is being hosted by the Brain Health Center of the Rockies. My name is Kathy Kiefer, and I am the co-founder, along with Dr. Augusto Miravalle, and the president of this nonprofit organization. Tonight, we will be receiving a presentation from Dr. Augusto Miravalle on COVID-19 and brain fog. Dr. Miravalle is a neurologist at Advanced Neurology here in Colorado. He is joined by Dr. Nicole Fleming, who is a board-certified health psychologist at Stress Management Family Counseling in Fort Collins, Colorado. The intent of our research club is to bring the latest development of recent academic journal articles and have them explained in a way anyone can understand. We hope that through this activity, participants will receive useful concepts that you will be able to apply to your lives in order to achieve maximal brain health. Research Club is a free program to participants. It is held 4 times throughout the year. Our final Research Club will be on November 7th, during which we will discuss food, nutrients, and the brain. As with all our research clubs, today's event is being recorded and will be made available within the upcoming days via our website, www.brainhealthcr.org. This program is 1 hour long. We would welcome you to use the Q&A box at the bottom of your screen to ask any questions you may have, and we will allow for time throughout the presentation as well as towards the end to answer any of those questions. Our moderator and co-chair for our research club is Dr. Brett Fling from Colorado State University. And before I turn it over to Dr. Brett Fling, I would like to highlight our sponsors for this evening, which include Biogen, EMD Serono, Bristol Myers Squibb, Genentech, and Novartis. You can learn more about each of these companies and their products by visiting the virtual exhibit hall on our website. At this time, I'd like to turn it over to Dr. Fling.
Thank you so much, Kathy, and thank you everyone for joining us tonight on a nice hot fall afternoon here in Colorado or wherever you might be. I want to thank everyone for joining us. This is, as Kathy said, our third in our series this year, and we've got one more left. So thanks to folks who are repeat offenders who've been with us before. And just as Kathy said, we'll encourage anyone who's interested or has thoughts or questions. You don't have to save them to the end. Feel free to type them into the Q&A, and I'll interrupt Dr. Miravalle repeatedly as usual, and we'll throw questions his way and Nicole's way as well. So please feel free to type questions in as you think of them, and I'll be your voice relaying them out here in the virtual world. Before we dive in, I'll give a very brief intro for Dr. Miravalle, and we're going to be looking and talking about COVID-19 and brain fog, and what you may have heard or read in popular media, or maybe you've done a deep dive on your own into some of the research articles out there on the potential long-lasting cognitive effects that come about following COVID. And I think that brain fog piece you might be familiar, I've heard in the past, with something akin to chemo brain. So for those who have maybe gone through chemotherapy sessions in the past for cancer treatment, similar, but also dissimilar in some ways that Augusto may talk to us about today, for how these infections can result in some long-term cognitive complications and effects. And we're gonna do a deep dive on them today. So I'll get out of Dr. Miravalle's way and let him take over.
Thank you, Brett, and thank you, Kathy, for opening, and thanks to Nicole Fleming for joining us. Nicole will have a critical portion of today's talk, which is what can we do to help fix whatever problems we acquire through this infection. But before we go to Nicole's section, I thought to give you a summary of what has been published, which surprisingly is quite a lot, even though this pandemic is relatively new to us. there's a large body of evidence now that has been published already in the neurological effects of COVID-19 infection. And before we dive into that data, I thought to do a very brief rundown of how do we get here. We know that through civilization we coexisted with a variety of parasitic forms of infections, anywhere from bacterial infections to viral infections. So this is not new to us. So what takes an infection to develop into a pandemic? It's this very complex interplay between social, biological, and actually economical factors that all together have to coexist in a way that allow for this infection to become this widespread pandemic, right? So it's not just a virus that determines the development of a pandemic. It's a coexistence between all these factors. And what makes a COVID-19 an interesting virus to actually, in a sense, fuel that pandemic is the fact that it's a single-stranded RNA. It's extremely simple. And sometimes things that are simple are the most dangerous ones, because that simplicity allows the virus to replicate very fast and also mutate. And that recombination and mutation and changes that the virus has almost constantly allows for that development of new properties that allows the virus to invade new organs, in this case, the central nervous system. So early on, we didn't think that coronaviruses were going to invade the central nervous system. They've always been thought to be primarily respiratory viruses, but as this virus acquires new forms, and of course is going to try to target those critical organs, that once involved in those organs, is going to be harder for the immune cells and the immune system to get rid of. So these are just stats out of today. Actually, I went to the WHO to try to get you the most up-to-date data on the incidence, cases, and death. And worldwide, you can see 613 million people, 97 million people in the US, that over a million people died from COVID-19 in the US, 6.5 million people in the world. Vaccines have been widespread. However, there's still a need for more vaccination in the world. And we are still seeing 470,000 new cases every 24 hours in the world. So we are not away from, and we are not even close to being done with this pandemic. Most patients recover, and we see that that recovery is a combination of many factors. Perhaps vaccination, of course, has to do with how we are recovering from this, but still COVID-19 is a critical and main problem from a public health standpoint in the world. So we started to look at the cognitive influence of COVID-19 very early in the pandemic. And this is kind of like a timeline that I put together to walk us through how we started to look into this. Very early on, researchers identified that COVID-19 affected neurocognitive functions in a way that was very similar to what we've seen with HIV infections. And we've been recognizing HIV-related dementia and cognitive decline very early in the HIV era in the 90s. And it's interesting that the cognitive decline seen in COVID-19 resembles that clinical presentation, which is different to what we see in Alzheimer's, even though the name dementia is used in both. It's a different type of cognitive decline. It's not as much as a memory onset problem, like an amnestic problem that we see in Alzheimer's, but it's more of an executive function. And we'll talk about what that means. Somehow, also early in the pandemic, we started looking at patients having difficulty with things like attention, memory, concentration, and processing speed. As Dr. Flynn mentioned, that chemo brain, right, that resembles the brain of people who underwent chemotherapy, for example, which again is a different subtype of cognitive decline. And as the pandemic evolved, the NIH and the researchers started to identify this cognitive decline in COVID-19. And there is now a term that is called the post-acute sequelae, or PASC, which is trying to kind of put a name or a label to this cognitive decline seen in COVID-19 patients. And just as a way to remind ourselves that one of the main functions of the brain is cognition, and cognition is more than just memory. So memory is just one domain of cognition, and usually we cluster together with learning, right? So learning and memory often goes together in this process of, getting information to the brain and the process of retrieval of that information to the brain. So the free recall, the acute recall, the recognition, semantic, long-term memory. So remembering people's names, remembering episodes, that's what we call episodic memory, but also remembering how to, follow certain steps in a complex activity, right? So if you cook, how to follow the different steps in a recipe, right? So that's procedural memory. It's part of what we call memory. But also the cognition includes what we call executive functioning, that ability to plan. Let's say tomorrow you want to do a chore in your house, and in order to do that you need to buy certain supplies in the grocery store, and in order to get to the grocery store you need to find the keys in the car and drive, and so on and so forth. So all the steps that are involved in planning an activity has to do with this executive functioning. You have to make decisions, you need judgment, you need common sense, as we call sometimes in layman's term. That concept of working memory, the steps involved in certain activities. Responding to feedback, for example. So if you're doing something and you made a mistake, you need to fix it and actually correct that process. So all of that has to do with what we call executive functioning. And this is one of the domains that is most preferentially affected by COVID-19. And you can see other domains of cognition here, which has to do with, for example, the perceptual or motor function, which has to do with this visual perception when you see things, and that visual perception allows for this constructional reasoning, saying, okay, I'm seeing things and I'm understanding that, and that's going to relate to an effect or some sort of motor coordination activity. Language is a big one that we actually constantly use, whether it's verbal or non-verbal language. That's part of what we call the cognition as well. And then, of course, attention, it's important. So attention is very heavily influenced by COVID-19, but also by things like depression and isolation and fatigue and sleep. All of the things are going to affect attention significantly. And I always tell patients, if you don't have attention, if you're not paying attention, that information is not getting to your brain. Of course, you're not going to be able to remember that, but it's not a memory issue, it's an attention problem. So in order for information to be stored, it has to first get to the brain. And that's the piece, that first step into the memory process requires attention. And last but not least, an area that was heavily affected by COVID-19 is this concept of social cognition, the ability to recognize emotions, the ability to relate to others. And through this pandemic, by the virtue of social isolation, we all been significantly affected by this domain of cognition. So you really can start to guess which areas has been directly affected by COVID-19. So this slide is a combination of multiple publications that I put together a summary of what they found. So in some studies, they found that up to 30% of people that were affected by COVID-19, and this was a study done in New York, over 120 patients, they had memory and cognitive decline. So that was 1/3 of patients. And these patients ranges from minimal symptomatology from COVID-19 to patients that went to the ICU. So it was not a clear relationship between how severe COVID-19 was and the presence of cognitive decline. In another study, they found that up to 80% of patients who had formal testing, and that was a study done in Chicago, 80% of those who actually did have formal testing, they had deficits in the neuropsychological assessment Of course, you may argue, well, if somebody ordered a neuropsych testing, it's because they already had some concerns, so it's a biased population. But it was interesting to see that process of selecting those patients resulted in a good selection, which resulted in 80% of those individuals having cognitive decline. In another study that was random, a selection of patients, by doing just a screening test, they found 80% had some cognitive decline. And spontaneous reports of brain fog by patients, 67% of patients in a primary care clinic found that they had some brain fog as one of their symptoms. And those were up to 3 months from the time of onset of COVID-19 infection. So you can see that this is kind of like starting to build a case of what's going on here with cognition and COVID-19. What are the risk factors? So throughout these publications, there are certain factors that make COVID-19 infection have a more likelihood of causing cognitive decline. And among those factors, you can see that the presence of attention deficit disorders, learning disabilities in kids in younger populations are known factors for subsequent cognitive decline. Particularly in middle age and later adulthood, the presence of vascular risk factors like the diabetes, hypertension, and stroke are factors that actually had some correlation to later development of cognitive decline. Of course, dementia and mild cognitive impairment. But interestingly, mood disorders, depression, anxiety, and heavy alcohol use are known risk factors now that those individuals who develop COVID-19, if they do have comorbid depression, anxiety, and heavy alcohol abuse, they are at a higher risk of developing cognitive decline later on in life.
Augusto, do you mind if I interrupt you for a moment?
Not at all.
We have some great questions coming in, and I'll encourage folks to feel free to keep typing them in as we're going along. Will you correct me if I'm wrong, Augusto, but it seems like from the work that you've been discussing so far, it seems like maybe the cognitive impairments we're seeing tend to be more in the executive function range so far following COVID. Does that seem right to you with the working memory and some of those components?
Absolutely correct. Yes, most of the time is this executive functioning, and we have a little bit more information coming on in future slides.
Okay, I was gonna ask, maybe if this is stepping on it, feel free to tell me in the audience to wait. But do we have a feel for why that's the case? Does COVID seem to potentially affect a specific area of the brain that may lead to this?
Yeah, there are interesting proposed mechanisms, and I do cover that in the next few slides. But those are great questions, and you know, every time we try to see these patterns, the big question is that why, and the reason why we want to know why is, so can we prevent it and can we do something about it? So there is this many studies now, but this one is perhaps the most comprehensive research effort that is primarily done at UCSF in San Francisco. That they are looking at, and this is an ongoing collaboration with many other universities, they're looking at the long-term impact of infection with novel coronavirus. Is known as the LINK study. So anyone can participate. That's something that is an ongoing collaboration, that what they're looking is individuals who develop COVID-19, and they do a series of tests, anywhere from surveys to blood tests, and in some cases spinal fluid analysis, to try to understand what is happening with these individuals in long term, because that's a big question, right? And of course we don't have an answer now, but is the trend that we are seeing now 2 years into the pandemic is something that it's going to continue to worsen? Is that something that's going to lead to, let's say, a dementia in the future? Of course we don't know, but that's why these efforts are being made now. But so far, what we are learning from this is that participants reporting cognitive symptoms had a median age of 41, and that's surprising, right? I mean, you will think, well, are we talking about 60 plus? No, we are talking about 40 years old, 50% female, so no gender predilection yet. 65% identifying as white, 30% identifying as Latinos, and then 10% Black, and 5% American Indian, which that is a very similar demographic that you will see in that area. So that doesn't appear to target any particular gender or any particular demographic yet. Seems to affect everyone. And so answering some of the questions, so these are the common symptoms that so far has been reported. So in the area of cognition, the most common symptoms are fatigue, decreased attention, memory loss, and poor executive function. In the terms of neurological involvement, patients also are reporting things like seizures and strokes. And interestingly, the strokes, all types of strokes, not only the ischemic strokes, but also hemorrhagic strokes, the bleeding in the brain, headaches, and dizziness. Psychiatric manifestations include depression, anxiety, obsessive compulsive disorder, psychosis, hallucinations, and paranoia. And I have to say, I've been involved with patients that had a completely normal background, and after COVID-19, they had episodes of psychosis and paranoia, and that's pretty much temporarily related to COVID-19. There was nothing else to explain that. And of course, there are infectious consequences of COVID-19 that includes encephalitis and Guillain-Barré syndrome. So these are the most common complications that we are seeing. This is another study that is a very similar approach, but in this case, worldwide. And this is a 2-year retrospective study looking at over 89 million patients. And those are patients that has been collected through multiple venues, anywhere from hospital, from primary care specialists, providers. And these are the countries mostly from the US, but you can see from Australia, the UK, Spain, and other areas. And this is very helpful. So what this tells us is the risk that individuals have based on age of developing certain problems. So there is a statistical technique called the hazard ratio that tells you what is the likelihood of an event happening in a given period of time in a given population. So for this study, they calculated the hazard ratio at 6 months. So saying, okay, if you are in the children category, which is anywhere between 0 to 18 years of age, and if you develop COVID-19, you will have X hazard ratio of developing whatever problems by 6 months. So a hazard ratio of 2, for example, tells you you have twice as much risk of developing this problem as populations without COVID-19 infection. So as you can see here, these dots correspond to the mean hazard ratio. And if you, for example, select in children, which is the first column in those green dots, if you look at, for example, encephalitis and Guillain-Barré, intracranial hemorrhage, that's a hazard ratio of 2. So what that tells you is that kids at this age group has twice as much likelihood of developing these problems if they did have symptomatic COVID-19 as kids without that infection. So that's pretty severe. And you can look at the adult group here, and of course the older adults, which are over 65. For example, if you go to things like Parkinsonism, you have a hazard ratio of 1.25. So you're 1.25 more likely to develop Parkinsonism if you are over the age of 65 and develop COVID-19 than if you didn't develop COVID-19. So that's pretty much a summary of what this large study showed. Here is the same study looking at different type of data, which has to do with what is the difference between those individuals who had COVID-19 and died versus those individuals who had COVID-19 and didn't die 2 years later. Is there any difference between the outcome of death, for example, determining the likelihood of different problems? So for example, if you had anxiety, mood disorders, cognitive deficits, epilepsy, is that going to increase the likelihood of death at 2 years? And conversely, those who didn't die at 2 years, what is going to happen with the incidence of those problems? And you can see that those in the darker lines, whether it's red or blue, are those who died at 2 years, and those with the lighter color, whether it's red or blue, are alive at 2 years. And that gives you a sense of the likelihood of developing things like insomnia, epilepsy, seizures, strokes, dementia, psychosis, and so on and so forth. So for the most part, you can see that certain complications increase the likelihood of death at 2 years. Among those is cognitive deficits. That's one of the perhaps strongest. Dementia, and of course, intracranial hemorrhage and strokes, Parkinsonisms, and psychosis. So those are the conditions that, when associated with COVID-19 infection, had a higher likelihood of death at 2 years, particularly in the older adult population.
Augusto, could I jump in with a couple of questions again? Do you mind?
Absolutely.
So, you were just talking to us about some of these maybe additional risk factors like Parkinsonism or Guillain-Barré syndrome. And certainly this year, there's plenty of news about Guillain-Barré and its association. Oh, I was actually thinking of Epstein-Barr, I'm sorry. But thinking about multiple sclerosis, do we know anything? We have a captive MS audience always at these meetings. Do we know anything about associations between COVID-19 and multiple sclerosis?
Right, and surprisingly, nothing has come up spontaneously from these, as you can see, these publications in MS specifically. There is a lot of data on MS and COVID-19 when it comes to treatments, right? So we know that for multiple sclerosis, the treatments that we use are immune suppressants. So we have a lot of information about how the use of immune suppressants in the context of a pandemic affect things like vaccine response to COVID-19, but nothing so far has shown that the infection with COVID-19 has been linked to things like increased risk of relapses or anything else. Of course, there is a lot of evidence that COVID-19 infection in the context of MS make things like fatigue worse, and of course, cognitive decline worse. I have a slide in the future now showing, for example, brain atrophy rates. And that's in everyone with or without MS. There is an increased rate of brain atrophy in people with COVID-19. So if you add that to an underlying disease like multiple sclerosis that already has an intrinsic rate of brain atrophy rate that is larger than usual, that of course, that coexistence could potentially worsen the rate of brain atrophy. But so far, MS has not been seen as an area that COVID-19 increases the risk of multiple sclerosis.
Do you have any thoughts on your previous slide, sort of building off of that? One of the things that you showed, it really looked like in the adults and in the older adults, one of the data points that really stood out to me was this myoneural junction or muscle disease as showing up as almost twice as likely from your hazard ratio equations here. Do we have any, is this potentially related back to some of the cortical atrophy pieces as well, or do you think this is independent of that?
That's a great question. And as you will see here, some of those are also dependent on the type of COVID-19. Now we have different variants, right? And here you have the same numbers with the same disorders, the same hazard ratio exercise, but now divided into whether it's the alpha, the delta, or the Omicron. So the alpha, you can see that on the blue, the delta in red, and Omicron in green. And you can see that also not only it depends on the age of the population, but also the type of virus is going to have a different type of involvement of certain complications. So you can see the myoneural and the muscle disease was more common in the Delta variant, and whereas you see things like nerve root and plexus, including the Guillain-Barré syndrome, are more common in the Omicron variant. So it seems like the type of virus also determines the likelihood of these type of complications. I have to say, personally, I got the Omicron variant and mine was all about musculoskeletal. I had back pain and muscle pain and I couldn't move. That was all muscle related, right? So I'm sure the different types, as you can see here, also has different clinical manifestations.
We did a great job of predicting some of our attendee questions, because certainly the different variants and their potential differences and effects was something that we were curious about. We have a few other questions in there that I think are a little bit more targeted towards how can we treat and or prevent these cognitive declines. So for those folks who asked those questions, I think we'll probably table those for a touch later in the presentation is my guess.
Very good. So moving on to other studies that, as you can see, this was January 2022, so relatively recent. There was a study that was in collaboration between UCSF and Cornell. They looked at the post-COVID cognitive decline in patients, and this was a smaller group, but they wanted to know, is there any link between the cognitive decline and markers on the spinal fluid? Of course, they had to do spinal taps, and that's why we don't have a lot of patients. But surprisingly, we found a lot of information. The spinal fluid, which is the closest we can get to the brain in some sort of testing, right? So it's directly getting the fluid that is in contact to the brain, showed a lot of interesting changes in those who had cognitive decline. So among those changes, of course, you had evidence of inflammation, but interestingly, inflammation inside the blood vessels, so what is called the immunovascular markers. So those markers are telling you that there is inflammation in the blood vessels, and perhaps that's one of the clues of why is this happening? Why do people with COVID-19 develop this cognitive decline? Is that a direct invasion of the virus into the brain, or is it a different mechanism? And this first column here that you see, this association of higher levels of immunovascular markers, is telling us that perhaps one of the mechanisms is through inflammation in the blood vessels. The second column in the middle shows also a markers of what we call immune activation. The IP10, the interleukin-8, there are certain growth factors that has been linked in patients with cognitive decline. And then we also started looking at markers of what we call reactive proteins, right? So acute inflammation and amyloid. And that was one of the first markers that started creating this link between Alzheimer's disease and COVID-19 that led to future studies now looking at what happened with the incidence of Alzheimer's in people with COVID-19. And I'll cover that in the next few slides. But this was one of the first studies that started looking at the presence of inflammatory markers in the spinal fluid in people post-COVID-19. And again, this is all individuals, not just people with pre-existing neurological conditions. So as I mentioned before, brain atrophy studies are starting to pop up, right? And this was a study that recently published in 2022 that looked at a large biobank of patients through the UK biobank. And they had over 400 cases of volunteers that developed COVID-19 infection. And they collected this between March and April 2021. And most of these individuals did okay with COVID-19. Only 4% of patients were hospitalized, but the majority of patients were not hospitalized. So this was a mild to moderate cohort of COVID-19 patients. And what they found is greater tissue damage in the areas connected with olfactory cortex. And we all know that, decreased sense of smell is one of the signs of COVID-19 infection. So the area right around the olfactory cortex, which is very much in the frontal and temporal region, has significant damage in the brain. But interestingly, those patients also had cognitive decline, and patients who had cognitive decline had a greater rate of brain atrophy. When you look at the whole brain atrophy, how much brain volume is being lost, that range anywhere between 0.2 to 2%. And I just want to put this into context. The rate of brain atrophy by healthy aging is between 0.2 and 0.4%. The rate of brain atrophy by multiple sclerosis without treatment is between 1 and 1.5%. So a brain atrophy rate of 2% is double the amount of brain atrophy in an MS patient without treatment. So this is a very large loss of brain volume. So 2% is significant.
Can I just ask my own question, Augusto? Because I think this is interesting.
Please.
So you indicated that one of the areas that they saw tissue damage or tissue loss was in the primary olfactory cortex, which tends to be close to the temporal cortices as well. That's also a very common spot where seizures originate from. Do you think this is one of the reasons potentially? Does that seem to really be one of the areas of the brain that's being affected selectively?
Absolutely, very likely, and also where memories are stored, right? So, anytime you change the homeostasis or the balance of the brain, whether it's through loss of brain parenchyma, whether it's through inflammation, you're changing that balance, and there are going to be consequences, where sometimes are short-term consequences, sometimes are long-term consequences, right? So it's perfectly fine to speculate that many, if not all, of the manifestations that we are seeing that are neurological in COVID-19 has a direct neuroanatomical correlate, whether it's through direct invasion of the virus, whether it's through inflammation, or in this case, through atrophy, right? So it's very good speculation. So as you can see in the reference list on the bottom, this is a summary of multiple presentations and research publications in the last 2 years that I tried to kind of cluster together and give a sense of what else is happening. So when you look at, for example, the study done at NYU, over 300 patients with COVID-19, they looked at, for example, the symptoms that they found. And this is when you start looking at the correlations with Alzheimer's and dementia. They start to see that the markers, the same markers of Alzheimer's that we measure, which is the total tau, the neurofilament light, the GFAP, and of course the amyloid beta 40 and 42, those same markers of Alzheimer's are actually being present in patients with COVID-19 infection. So we don't know yet what that means, right? Of course, this is too early, but the conclusions of these publications are suggesting that perhaps this is process of acceleration of the neuropathological markers, the same ones seen in Alzheimer's disease. So time will only tell, right? So it's too early to tell. Are we ready to say that COVID-19 increases the risk of Alzheimer's? We don't know, but the fact that we are seeing the same markers in these individuals that precede the onset of Alzheimer's disease up to 20 to 25 years prior to Alzheimer's is something of concern. We don't know where this is going to lead us. So going back to the mechanisms, so these are the ones that has been proposed. So of course, anytime you have an infection, there is this potential immune dysregulation. So you are changing the immune system. And one of the theories that has been proposed is the direct development of antibodies against neurons. And perhaps that's one of the easiest way to explain atrophy, right? So if your immune cells get confused, you have this massive activation of cells to a new virus. And among those, there could be what we call the bystander activation of other cells that randomly developed antibodies. And if the target in this case is a neuron, perhaps you have these anti-neuronal antibodies. Another proposed mechanism is direct activation of inflammatory cells in the brain. And, you know, those macrophages that we call the microglia in the brain, when they get activated, they get nasty and they're gonna try to fight anything they can. So microglia activation in the brain is never good. And there are now multiple studies looking at post-COVID-19 microglia activation. Another mechanism is what we call complement activation. And I have a picture because it's fascinating. Complement is this first line of attack. I always explain to my medical students, complement is your army, right? So if you go to the war, the first line of defense is your complement. Very much non-specific. It's more about this destruction. You try to destroy everything you can. And when the complement gets activated, it can get really destructive. And so complement activation is wonderful to fight infections, but it's terrible when you have it activated in the wrong place. And there is now a lot of evidence that there is complement activation in the brain in post-COVID-19 infection. We talked about the sense of smell, and there is a direct link between the invasion of the virus into those neurons in the olfactory bulb. And you know, the way we were designed is in order for those smells, which is a defense mechanism in animals. When we smell something that is dangerous, that information has to go quickly to the brain so we can run away, right? So the way we are designed is that those neurons are pretty much exposed. So there is a small little lamina of bone that separates the nose to the brain. And that's where the neurons are that allows us to smell. That's why it's so dangerous to smell cocaine, because you're directly breaking that barrier, right? So that's one of the many things that we tell people, don't do those things, right? But in the case of COVID-19, when the virus gets to the brain, it has minimal barriers. And that's one of the potential mechanisms in which the virus can, through a process of called retrograde axonal transport, get from the olfactory bulb all the way to the brain. And guess what is one of the first stops? The temporal lobe, as Dr. Flynn mentioned, that area that allows you to store memories. I'm going to pause here and give you a trivia question. How many of us here, when you enter a place and you smell certain things, that triggers memories, right? Whether it's cookies or you smell Christmas and that trigger a memory of Christmas, right? So there's a direct link between the sense of smell and memories. And that link has an anatomical correlation to the temporal lobe. And last but not least, another mechanism of potential cognitive decline in COVID-19 is what we call secondary, right? So through depression, poor sleep, pain, isolation, stress, all of the things can affect cognition. So this is kind of like a summary of the proposed mechanisms in which COVID-19 can affect cognition.
Gusto, I'll jump in with another question from the audience. First off, I didn't know smelling cocaine was going to be mentioned. This is quite a presentation. Gusto's taken us through. If you've joined us for a lot of our research clubs, exactly a year ago, one of the things we spent a bunch of time talking about was Alzheimer's disease and related dementias. So things that are like Alzheimer's, but different type frontotemporal dementias, et cetera. And so one of our questions from the audience is when you're saying that there are some maybe Alzheimer's related symptoms and pathology that are sparked by the COVID-19. Is that all Alzheimer's specific, or are we talking about maybe sort of dementia more generally speaking?
Yeah, so these markers that we talked before, the phosphorylated tau and the A beta 42 are markers that are specific for Alzheimer's. However, as we mentioned before, we don't know where this is going to take us, right? So the neurovascular markers that I mentioned before, those are in the blood vessels, are also seen in patients with vascular dementia. So it is possible that some of these markers coexist and they could lead to different types of dementia. So these are some of the cartoons, and this is all new. So these cartoons are slowly popping up now in the literature, but this is showing us how the speculation is that the virus itself, for example, activate certain cells, those cells in the blood vessels. So what you see in the middle, and I never know if I move my cursor, if you can see that, but I'm still going to do it. So this is a blood vessel here.
Yes.
You can see that, okay. So these red cells are the red blood cells, and you can see an immune cell trying to go through that. And when that happens, it's going to cause inflammation and destruction in the cells in the inner layer of the blood vessel. We call those endothelial cells. So when that happens, it's terrible, because guess what? Now that a cell is destroyed, that's going to cause inflammation. And anytime you have inflammation, the red blood cells are going to try to patch it. Say, okay, nothing happened here, right? So when you're trying to rub things under the rug and say, okay, nothing happened, let's just pretend nothing happened. So the red blood cells are going to go there and cause a clot. And blood clots are bad because they can cause strokes. So one of the mechanisms behind stroke is this concept of damage to the endothelial cells through neuroinvasion and inflammation and subsequent clot formation. This is what I was talking before, this complement activation. So I want to bring you here. So this is a blood vessel, immunoglobulins, antibodies, activating complex, a complement. The ultimate result of complement is this aggregation of complement called MAC, or membrane attack complex. So I told you before, the complement is like the army. The MAC is like the CIA, FBI all together. So they come there, and what they do is they aggregate, and that happens all the time, and they create a whole. So a MAC is pretty much an aggregation of proteins to create a whole and say, okay, enough of this, we need to destroy whatever is happening. So that membrane attack complex is ultimately going to damage the endothelial cells, and that damage of endothelial cells has two consequences. One is more inflammation, platelet aggregation, and clot formation, also strokes. But the other one is that now we have a hole that was created in the endothelial cells of the blood vessels in the brain. And that is a port of entry for anything to the brain, anywhere from inflammatory markers to viruses and so on and so forth. So complement activation is pretty much saying we're going to break that barrier in the brain and allow anything to go through. And that is a consequence of COVID-19 infection. And this is trying to link more subsequent consequences of that, which is after all of that happened, there is what we call stress. And that stress is throughout the body, right? So there is activation of the pituitary axis to the hypothalamus and the adrenal glands, estrogen, hormones, stress, cortisol, peripheral inflammation, and you name it. So all of these things, we have no idea what's going to happen, but they've been linked to things like depression, bipolar disorder, PTSD, psychosis, and so on and so forth. So before I jump to now what do we do now? I want to make sure that there are no questions that we can address in the mechanisms or symptoms.
Yeah, so I think at this point, all of our Q&A is based around now what. We're interested to know what we can do next. So you're
Okay.
just right on timing.
Excellent. So this is just my view, but of course, there are many other things you can do. I will say the first thing, if you think that you have cognitive decline, if you had COVID-19 infection, or even if you don't know, but you feel that your cognition is different, I will say just talk to your doctor, healthcare provider, talk to a primary care physician, neurologist if you have access to, and let's just sit down and talk about what's going on. Usually that results in a careful physical exam, a history. We may do an MRI to just see what's going on in your brain, if there is anything we can learn from that. And we may do a cognitive screening. But let me tell you, what I've been reading so far is that the traditional cognitive screenings that we use in the clinic, the Mini-Mental or the MOCA, they are normal. And even though in patients with then abnormalities and formal cognitive testing. So in COVID-19, these cognitive screening that have been developed for dementia are insensitive. So they shouldn't stop there if the cognitive screening is normal. Usually that results in referring patients to a neuropsychologist to do a formal neuropsychological testing if you really want to know what's going on. I always recommend to rule out other causes of cognitive decline, anywhere from vitamin deficiencies, abnormalities in your thyroid, syphilis is becoming a very popular infection nowadays, that people think that HIV is controlled. They just drop barriers and they get infected with syphilis. So we need to start looking at those things again. Of course, eliminate all these secondary causes, sleep apnea, medications that perhaps may affect in your cognition, depression, anxiety, and those coexist, and then refer patients to occupational therapists, physical therapists, sleep studies, and so on and so forth. So that pretty much concludes my portion of the presentation. And I'm leading the most challenging part of that, which is, what do we do now to Nicole?
Well, I don't know if I have all the answers, but I think given my background in working in health psychology, I've definitely seen a lot of patients present with brain fog, which may or may not be related to conditions as mentioned, like HIV, multiple sclerosis. I've seen in working in chronic pain management, a lot of patients report brain fog with fibromyalgia. I know at one point when I was working in northern Minnesota, we were sending patients down to the Mayo Clinic to get neuropsych evals done for patients with brain fog. So that's often commonly reported. We also see a lot of patients with chronic fatigue syndrome, and as also was mentioned, I guess the chemo brain, or after chemotherapy treatment, which I can anecdotally attest that yes, that is a real thing. I did undergo chemotherapy, and it definitely does create some challenges cognitively. You know, the things that I kind of, in looking at some of the different articles out there specific to health psychology and ways that our field can help assess and intervene is, you know, first of all, kind of identifying the chicken or the egg phenomenon, right? So a lot of times if you have the cognitive issues related to COVID-19, that could lead to frustration with day-to-day functioning, meaning you're more inclined to become depressed or anxious as a result of your symptoms. And then we also know that if you are depressed or experiencing anxiety, or even other disorders that we've seen, like post-traumatic stress disorder, that can also lead to cognitive issues. So being able to tease that out oftentimes can be a challenge. I know that having the neuropsychological evaluation completed can kind of help tease out if it looks to be more of an organic or medical cause versus it's related more specifically to the depression, anxiety. But to speak to just even, the impact that COVID can have on a person's mental health, there was a meta-analysis that was done in 2021 that looked at they called it a pooled prevalence of depression and anxiety, and it was upward of like 45% of patients who had COVID-19 then experienced depression and anxiety. And they were also looking at like if you've never had depression or anxiety in the past, that people were having their primary onset of a major depressive disorder or an anxiety disorder at 8.63%. So that's kind of significant. If you've never dealt with depression and anxiety your whole life, and then you have COVID, now all of a sudden you're experiencing mental health problems. And it's, again, a lot of it's just adjusting to the illness, right? This illness has had an impact on me medically, cognitively, and now how I interact with the world. How am I coping and adjusting to the world in that regard? I thought it was also interesting that post-traumatic stress disorder has a prevalence rate of 6.5% within the first 2 months after having COVID-19. And so if you kind of think about, the collective trauma that everyone has experienced with this pandemic, in addition to what people might experience as they go through medical treatments, along with just, kind of the isolation and the fear associated with the symptoms that you may be experiencing. So some of, I guess, again, what we can do, I think the neuropsych eval is always an option. However, I think that more of the research now is looking at, getting patients into like a cognitive behavioral therapy, either with a psychologist or someone, who's a counselor trained in doing cognitive behavioral therapy, who can at least help patients not only adjust to their illness and how it's impacting their quality of life and their daily functioning, but also, being able to really identify some of the catastrophic thoughts or the unhelpful thoughts about your illness and learning ways to kind of reframe that into what I call more positive coping thoughts. It's focusing on some of the acceptance and adjustment to change. There may even be behavioral strategies that can be used to kind of manage and help accommodate with certain limitations. When I see patients that are experiencing cognitive issues, I might also then, in addition to treating the depression and anxiety or other mental health conditions, help them to specifically know ways to function better when they're interacting with other people. So, I need to not have as many distractions around me when I'm having a conversation so that I can focus and sustain attention. Perhaps I need to write down what is being said so that I can recall the conversation, keeping, calendars and diaries, journals, things like that, so that you're keeping track of what's going on is another helpful tool. Any questions coming up so far as I'm kind of rambling on about the different aspects of dealing with COVID from a psychological standpoint?
So Nicole, I'll jump in and ask you if you could maybe give us a bit of a bird's eye view of, a neuropsychological evaluation. I think always sounds a little bit daunting maybe to folks. So could you walk us through, briefly what that looks like? Is it simply an interview? Is it a pen and paper test? What do we have to do for that?
Yes, that's a great question. So a lot of times, if you're working with a neurologist or a primary care physician, or even if you already have a psychologist, they can kind of screen a person for maybe some cognitive issues that they're having and see if they would then benefit from a neuropsychological evaluation. A neuropsychological evaluation is a very comprehensive assessment that can take anywhere from 4 to 6 hours, and that is an approximation. It can be longer. It can be over a course of a couple days. And what it is, it's basically a way to kind of assess for cognitive strengths and weaknesses that would then focus on the different cognitive domains that Dr. Mirvali was speaking to, whether it's specifically memory, processing speed, like how fast you process information. A lot of people may have slowed thinking after COVID, looking at attention concentration, also executive functions, which are the, problem solving, planning, thinking ahead, decision-making, impulse control. So a neuropsychologist may have someone who sits in a room with you and does some different assessments to see like how well you're able to remember information. You may put some puzzles together, you may do some drawings, and these different assessments have been looked at time and time again and researched to see how we can actually tease out and see where a person may be struggling with their cognition.
Yeah, that's perfect. Thank you very much, Dr. Fleming.
Any other kind of, I guess, questions for me about cognitive behavioral therapy and how that may work for helping a patient recovering from COVID or with brain
Nicole,
fog?
I have a question for you.
Yes.
Usually, how long would you say it takes for a patient with cognitive decline after COVID to see some benefits of cognitive behavioral therapies?
So of course, there's probably not, well, I wasn't able to locate any information or research out there yet on the number of sessions that it would take for a patient to see benefit from psychotherapy to address those, whatever issues are presenting. Typically, the rule of thumb is kind of around 8 to 12 sessions that you may be working with a clinician to start to see some benefit. I think it's important though to remember that for the most part, what our goal is to help patients manage their symptoms. So there's not, there's not a cure, there's not a magic medicine as far as we know. I think we're still trying to identify what some of those different things might be, even if it's, from a psychopharmacology standpoint, if there's specific medications or stimulants that might help with cognition. However, I think, if anything, it's again, like I said, managing symptoms and learning how to kind of transition through the world with some of the challenges that you may have initially experienced. And then also like working on getting the anxiety and depressive symptoms to decrease, because if we see those decrease, we may actually see cognition improve.
Yeah, I really appreciate that perspective, Dr. Fleming. Thank you for sharing. I think that's one of the things that's always really important to point out to individuals, right? Is that it's not that we're going to turn things around. And, when you say we're seeing the benefits of CBT, it's not necessarily that maybe cognition is improving and going back to where it was a year or 2 years prior, but it may even be just in terms of slowing decline or attenuating that decline.
Exactly.
Wonderful. So I think if there's no other questions from the audience, I think we can wrap things up. I would like to give a big thanks to Dr. Mirvali, as well as Dr. Fleming, for your presentations and discussions this evening. Of course, thank you to Dr. Brett Fling as well for being our moderator. I would like to recognize once again our sponsors for this event, which are Biogen, EMD Serono, Bristol Myers Squibb, Genentech, and Novartis. I would like to highlight another event that is going to be upcoming for the Brain Health Center of the Rockies, which is our Brain Health Fair. That's going to be on Friday, September 30th here in Northern Colorado. There's additional information on our website. It's an afternoon event where we will have free screenings. We'll have a bunch of exhibitors as well, and our keynote speaker of Dr. Nicole Earhart. So hope folks that are local and are currently on this webinar will be able to participate in that as well. Do continue to check out our website for future events. And on that note, I would like to wish everyone a great evening and thank you so much for joining us. Have a good night.